an honor to me to introduce and present my big brother, one of the most famous figures in the field of epilepsy and the head of the epilepsy chapter in the Egyptian Society, Professor Dr. Hassan Hosny, who will give us a talk about epilepsy in the elderly, which is a very important sector we are usually dealing with in our clinical practice. تفضل دكتور حسن.
دكتور محمد على الانترودكشن، وطبعا مبروك حازم معروف والدكتور اشرف عبد. دكتور محمود حميده معانا برضو، احب ارحب بيه. وطبعا اهلا وسهلا. وطبعا دكتور توفيق السعدي، انا سعيد جدا ان انا سمعت صوته. ازيك يا توفيق؟
والله الحمد لله
كله تمام؟
كله تمام الحمد لله تعالى، الحمد لله.
ان شاء الله نتقابل قريب
ان شاء الله ان شاء الله.
انا الموضوع اللي هتكلم فيه النهارده I think it's important as we can see in elderly population، وانا فضلت اتكلم اسميها seniors and epilepsy على اساس ان يعني ان احنا بنشوف السينيور citizens it's more diplomatic بدل ما نقول elderly population. وحتى ال WHO دلوقتي is changing the definition of the elderly population. There is definitely an increased incidence. Just a second. There is definitely an increased incidence of epilepsy in the elderly, and this can be attributed to the increased age and aging-related epileptogenic conditions. You all see patients with strokes in the elderly, with dementia, and we often see seizures. This is a special population, multiple comorbid conditions, and definitely we should choose the right medication according to the comorbid condition. The talk I'll be discussing today is, if you look at the numbers, it's very obvious that epilepsy and seizures, even acute symptomatic seizures, are more common and get much higher with elderly population. The mechanism underlying aging and epilepsy is important as a neurodegenerative process. The etiology is certainly different because we don't see patients with cortical dysplasias, mesial temporal lobe sclerosis. ما بنشوفش الباثولوجيز دي، بنشوف different pathologies, etiologies. Even the clinical presentation is different, and this is very important because of the under and over diagnosis of epilepsy. Treatment approach, obviously, it's different because stroke with patients and dementia with epilepsy and post-traumatic, I think we should choose the appropriate anti-epileptic drugs according to the comorbid condition. Not the least to stress upon the incidence of status epilepticus is higher in the elderly population, and the morbidity is quite high after the attacks of status epilepticus, whether it's convulsive or non-convulsive status epilepticus. Let's look at this slide. We always classify a very simple classification of epilepsy, whether it's focal or partial onset seizures, or generalized epilepsy. And from this slide, it's very clear that if you get a seizure after the age of 60, definitely you are dealing with a case of partial onset seizures or focal epilepsy. Of course, it does not depend on the semiology. It's a partial onset seizure. Semiology is what you call a seizure type. But we don't have any generalized epilepsies in the elderly population. If you look at the numbers, the age-specific incidence is, if you're between 45 and 59 years, 10 in 100,000. If you reach 60 or 74, 25 per 100,000. And if you're over the age of 75, 100 per 100,000. So it's very clear that age plays a role in the incidence of epilepsy as you get older. The incidence of acute symptomatic seizures is also higher with increasing age. Status epilepticus is 2 to 5 times more common in the elderly than in the younger adults, and obviously mortality rate is elderly may be high as 50%. So this is very important to consider that epilepsy is higher in the elderly population as well as status epilepticus, whether it's convulsive or non-convulsive, and the mortality is quite high. The causes of new onset epilepsy and seizures in the elderly, of course, it's different. We're dealing with cerebrovascular diseases, with primary neurodegenerative diseases, intracerebral tumors, and traumatic head injuries. The most common etiologies in epilepsy in the elderly, the cryptogenic is around 50%, stroke from 30 to 50%, dementias from 10 to 20, whether it's Alzheimer or non-Alzheimer, tumors 4 to 6%, and trauma. We should also not forget that the paraneoplastic autoimmune causes of epilepsy are being increasingly recognized in the elderly population, and this should lead a lot of lab work to find the etiology of the seizures in the elderly. The acute symptomatic seizures, which is not epilepsy, of course, is you can find an acute stroke. In the acute stroke setting, you can find an acute symptomatic seizures. It's related to the size of the infarct, the severity of the stroke. You can find, of course, the metabolic electrolyte imbalance disorders presenting with seizures, like uremia, like diabetes, uncontrolled diabetes, and electrolyte imbalance. Tumors also can present with seizures, acute symptomatic seizures. Trauma, depending, of course, on the severity of trauma. Acute symptomatic seizures, depending on severity of trauma. And drug-related seizures, of course, we have a lot of antibiotics, especially in the elderly, which can provoke seizures. And central nervous system infections we should not ignore. All this is presenting with acute symptomatic seizures, and then a percentage develops epilepsy afterwards, usually in the first 6 months after the insult. The clinical presentation is non-specific and may take time before a firm diagnosis. Symptoms not recognized, but usually you say, the effects of aging, other medical conditions. So underdiagnosis and misdiagnosis are common. As we said, it's a partial onset seizures, so focal epilepsy. So we always expect the semiology you see in the younger population. Focal onset impairment of awareness is common. Frontal more than temporal, like in stroke patients, just impairment awareness. Don't expect patient will tell you I have an aura or I have automatism in the elderly population. It's not like the younger population. Increasing frequency of atypical events, the memory lapses, confusion episodes, altered mental status, attributed to aging or medication, and it could be a seizure. And what's really important, I think you should stress upon, is the post-ictal states. You can find the patient diagnosed as having a new stroke simply because he has a post-ictal weakness, post-ictal paresis, and it can last up to 2 weeks, and he can be as a stroke. And it's not a stroke, it's simply a post-ictal phenomenon. The same applies with memory impairment and confusion following a seizure. So it's important to recognize that the post-ictal phenomena in the elderly population can be quite prolonged, whether presenting with paresis or confusion or a memory. So this is important not to erroneous diagnosis of dementia. The French diagnosis of epilepsy in the elderly, I think it's worth to state, Bardo, is the TIA, you see it, TGA, transient global amnesia, which often we see it. TIA, I would like to stress upon it. I mean, if a patient is coming with frequent stereotype TIAs, I think it's unlikely it could be vascular. We should think of a seizure, okay, or a negative motor phenomena. يعني صعب جدا a patient coming every time with weakness and resolving, and still we are insisting it's a vascular phenomenon. It could be simply a negative motor phenomena or a negative motor seizure. Endocrine metabolic disorders, and then as hypoglycemia or hyponatremia, syncope is very common syncope. And I think it's worth a cardiac evaluation and Holter monitoring, because often you find an arrhythmia and the patient falls. And depending on the fall, whether it's sudden drop in blood pressure, he can get stiff with urinary incontinence. REM behavioral disorders, of course, we all know it signals in neurodegenerative disease. Parasomnia is usually in the younger population. And psychological non-epileptic psychogenic seizures is also possible. But I think what's very important, you have to rule out arrhythmias, okay, postural hypotension, and TIA and TGA. This is the prevalence of non-convulsive status epilepticus in the elderly and acute and confusion state. I'd like to stress these are really sick patients, and the confusion states or the non-convulsive status epilepticus signals a severe brain insult to the brain. So non-convulsive status epilepticus is manifested as altered mental status, unusual behavior, unresponsiveness. It accounts to 20% of all cases of status epilepticus. Only 1/3 of patients have a history of epilepsy. And this is important to know. So it's not, 2/3, they don't have history of epilepsy. High mortality, about 50%. And as I said, it's related to the underlying process rather than duration. And the VA studies found that 65% of patients with non-convulsive status epilepticus died within 30 days of an episode, compared to 27% of patients with generalized convulsive status epilepticus. And this tells you that the non-convulsive status epilepticus patients you see in the intensive care ICU, neuro ICU, have a severe brain insult, and that's the reason of their death. Prognosis of status epilepticus in the early is important also. It's a serious condition of prolonged and repetitive seizures. Annual incidence is around 86 per 100,000 above the age of 60 years. It's twice as common in the general population. Half of the patients of status epilepticus do not have a diagnosis of epilepsy, and this is important to know, and it's often triggered by an acute illness. Mortality increases with age, etiology, and duration. So this is just covering the part of non-convulsive and convulsive status epilepticus, confirming the brain insult and the duration is the main etiology causing mortality. Let's talk about the etiology. Stroke is very common. It's a strong association between stroke and epilepsy. We have to define what's early seizures and what's late seizures. Early seizures occurring within 7 to 14 days after the stroke. And there's this type, what we call acute symptomatic seizures. And usually you see it with big cortical influx to the brain. Late seizures defined as seizures occurring more than 7 days after the stroke. And this type of seizure, we call it as unprovoked seizures. The risk of subsequent unprovoked seizures was 33% among subjects with the first acute symptomatic seizures and 71% among individuals with the first unprovoked seizures. So in other words, that if you have 100 patients with acute symptomatic seizures, 1/3 will get late seizures. And if you get the late seizures, 2/3 will have recurrent seizures. So it's important to take this into consideration whether you're deciding to give treatment or not. The relationship between stroke and epilepsy is bidirectional. Risk of stroke is increased 3-fold in patients with late onset seizures or epilepsy. It signals that it's probably the etiology of epilepsy is a microinfarct, and this is signals that the patient might have stroke later on. We always see MRIs, people coming to our clinics and really scared, white matter hyperintensive, cortical volumes, and late onset epilepsy. I think we should not stress a lot about what you see on MRIs, because we see a lot of MRIs and white matter hyperintensive and cortical volumes. And I think this is more of an academic issue rather than signals a late onset epilepsy. So this is important to know about whether you find the MRI will be helping you, whether this patient will develop a late onset epilepsy. And this is a case I saw 10 years ago. And by the way, I saw him today. This man, I saw him 10 years ago with this intracerebral hematoma. And as you can see, he had no seizures, just presenting with this hematoma. The only predictor that he might get a late seizure is that it has a cortical location. And this is his, as you can see, his EEG is showing right slowing, consistent with the hematoma. And what happened is that later on, 4 years later, he came to me with the first seizure. He's controlled, I've seen, he's controlled on a low dose of the antiepileptic medication, anti-seizure medication, but tells you that the seizure occurred 4 years after. By the way, this is not the common. What you see in general, late onset epilepsy, whether it's traumatic or stroke, usually you see it in the first 6 months after the brain insult. But this was exceptional that he got a seizure 4 years after the brain insult, which is a hematoma. Let's move to dementia and epilepsy. 10 to 20% of epilepsy in the elderly is due to dementia and neurodegenerative diseases. 10 to 20% of Alzheimer's patients have epilepsy. It's a difficult diagnosis because the patient is already demented. So, you can't depend on the altered mental status, except if the caregiver is very intelligent and recognizing the changes in behavior. Early onset dementia, 50 to 59 years, have 80 times higher to develop seizure compared to the general population. And this is just a prediction how to association between epileptiform abnormalities and seizures in Alzheimer's disease. I think you have to be an excellent EEGer to address this point. And the results is that the epileptiform abnormalities are common in Alzheimer's dementia, but not at all equivalent. Specific features of epileptiform discharges are associated with clinical seizures in Alzheimer's dementia. Given the difficulty recognizing seizures in Alzheimer's disease, these EEG features could provide guidance on which Alzheimer's dementia patients are high risk for clinical seizures. And this is just I'm saying, we have to be very practical in the way we see patients and address the problems. I can't do just an EEG for a patient with dementia, and I look at about the EEG abnormalities. Post-traumatic epilepsy, of course, it's on the rise. It's very important. Age of when you get older, the risk of developing post-traumatic seizures is higher compared to the younger population, and seizures are pretty serious because they lead to falls and injuries. The influence of age on the outcome of traumatic brain injuries from a Japanese nationwide study, and clearly it states that as you get older, you're more prone to having a post-traumatic epilepsy. The last etiology I'll be discussing is the brain tumors and epilepsy. 10 to 30% of seizures in the elderly, more likely to occur with low-grade, slowly growing tumors compared to other brain tumors. The point I'd like to stress upon is that if a patient with a brain tumor is presenting with seizures, I think this patient it's warranted to give him anti-seizure medication because this presentation was a seizure. If the patient, I'm saying this for neurosurgeons, basically, the presentation of brain tumor was not epilepsy, you might consider stopping anti-seizure medication after 6 months. So if the patient is presenting with epilepsy, he should be on lifelong treatment with anti-medication treatment. Treatment approach, as we said, it's all focal epilepsy, partial onset seizures. You choose which anti-epileptic you like to use, except ethosuximide, obviously, because it's a narrow spectrum anti-seizure medication. Elderly population are more likely to respond to anti-seizure medication and at a lower dose than required in younger patients. The most important thing, dropout rate, start low and titrate low. We're not in a hurry. Seizure frequency in the elderly, you don't find the patient, the elderly coming, tell you I'm having 3 seizures per week. So we're not in a hurry. Start in a low dose of anti-epileptic drug and gradually build up the dose till you reach the target dose, which is usually less compared to the younger population. The special treatment or problems with the pharmacokinetics, we have hypoalbuminemia, we have the reduction of liver mass, renal clearance, and reduced absorption due to delayed gastric emptying. So these are all factors affecting the anti-epileptic drugs pharmacokinetics. Obviously, the old AEDs are enzyme-inducing medications, so this is important to recognize when you're giving with blood thinners, okay? Many anti-epileptic drugs known to have cognitive and behavioral side effects, which may exacerbate or mask cognitive and behavioral symptoms of comorbid diseases. And this is just to tell you about looking at the cognitive and behavioral side effects of the anti-epileptic drugs in general. You see them basically on 2 populations. You see them on the elderly population, and you see them on the younger people population with mental disabilities. So the behavioral side effects of cognitive are very pronounced into these 2 populations. So it should be very cautious about the side effects in the elderly population. This is a list of advantages of anti-epileptic drugs. I won't go into detail. I mean, oxycarbamazepine, sodium channel blockers, carbamazepine, all they have the problem of hyponatremia, which is more pronounced. in the elderly. I mean, it's a long list, but this is just a slide telling you randomized double-blind comparison antiepileptic drug treatment, elderly population, comparing levetiracetam with carbamazepine, seizure freedom and lamotrigine. Seizure freedom was the same percentages. Obviously, of course, lamotrigine scored better with less cognitive side effects. So the initial monotherapy of focal epilepsy in the elderly, 1-year retention, which is very important, levetiracetam, was higher compared to carbamazepine due to better tolerability. Retention of lamotrigine was intermediate, though, and dosed was intermediate and dosed to close to levetiracetam. So basically, of course, levetiracetam scores higher and lamotrigine compared to carbamazepine. And this is the study. It's carbamazepine, gabapentin, and lamotrigine. It's an old study. It's by Rowan et al. Still recording about retention and side effects. And of course, carbamazepine scored the lowest in terms of, not in terms of seizure freedom, but in terms of cognitive side effects. Mechanisms about the neurodegenerative process and epilepsy, the free radicals, the sodium channel pump. I mean, it's all theories about the mechanism underlying aging and epilepsy, oxidative stress, mitochondrial oxidative stress, glutamate excitotoxicity. So I think my conclusions are epilepsy in the elderly is an important and growing problem. Clinical manifestations and causes are different from the younger population. Diagnosis is challenging because of the misdiagnosis and the overdiagnosis. The question is, does the aging brain is more prone to epilepsy? This is an open question, need research. Status epilepticus is higher compared to the younger population, and the morbidity is higher. Natural history of epilepsy in the elderly is unknown. And understanding the mechanism, just what happens, and understanding the mechanism underlying epilepsy and stroke and neurodegenerative stages is worth studying.